are online.
This time I shaved.
All right, so let me begin with the reminder that we meet again on Wednesday, same time, same place, for the general discussion. I got a few questions from the members of the school, and if you want to add something to that list, please do it, but please do it quickly, because tomorrow I plan to share the questions with all the speakers, and I hope that they will, well, take a little bit of time getting ready to answer them. But of course, you are welcome to join without asking questions, or without asking questions in written form, but then asking them in real time, so that you get unprepared answers for the faculty, which may be more fun, of course, from the speakers, I mean. Okay, all right, so we are ready for our final scheduled talk, and it's great to have Mindy here, who is also a regular speaker in the summer school program. And finally, we will learn something today that's useful, because Mindy is applying things to real-life problems, or to clinical real-life problems. So I think I'm going to stop now. So Mindy, why don't you take over and do anything you wish?
Okay, Mark, thank you. So just a big thank you to you, Mark, for you and Louise for organizing the summer school, the second virtual one, and the, you said 18th, 19th, actual virtual or actual summer school. It's always a pleasure to do this because we get a chance to talk about a topic in a relaxed setting and have a lot of interaction, which is what we need in order to move forward and increase our ability to disseminate our knowledge. I'm sorry, been a bit of a distracting weekend. We won't go into that. Okay, so I'm going to talk about, I'm going to have to share my screen first. So do you see my screen?
Yes. Yes.
Okay, great. And now I'm going to put it on mode of presentation mode. Okay, yep. You see the big screen. Okay, great. Okay, so I'm going to talk about threshold position control and implications for normal and disordered motor control. I'd like to acknowledge that a lot of this work has been done in collaboration with Anatole Feldman, my colleague, and really, though, it's been oriented towards understanding the deficits that occur after lesions in the brain and how those manifest themselves in disordered motor function. So first I'm going to talk about the clinical context of what is stroke to give you a bit of a background for those of you who are not that familiar. Am I speaking loudly enough? Should I get closer to the mic? It's okay?
Sounds perfect.
So then I'm going to use stroke as an example of disordered motor control and specifically describe or provide a potential explanation for the disordered motor function due to deficits in threshold position control. First, I'm going to run a movie. This is quite an old movie, but actually it's quite illustrative of what reaching deficits look like in people with different levels of severity of stroke. So in the first example, you see a man who's reaching. He has pretty good function. You wouldn't see it was very, very disrupted, except that he's moving very slowly. And this is very characteristic of people who've had stroke. That movement speed is much slower. See a little bit of discoordination and lack of fluidity, though, in the movement of the endpoint. In the second patient, she's had a more severe stroke. Her movements are much more jerky. They're also slow. And you see a little bit of problems with the coordination between movements of adjacent segments like wrist extension with elbow extension, which is disrupted and often is causing problems in grip formation. It's more evident in this patient who has a lot more difficulty lifting her wrist. You can see that she can't, or she has difficulty extending her elbow independently of her shoulder moving as well, and the shoulder and trunk and elbow are all moving together. So 3 levels of severity, and they do have similar problems, but they certainly the level of severity is important when we are trying to understand the deficits. So briefly, I'm going to go over what we think is happening in stroke. This paper was written to describe the origin of spasticity, but it does give a nice sort of cartoon view of what's happening after a stroke. So briefly, stroke damage leads to loss of inhibition in the interspinal network, resulting in reflex dysfunction and abnormal muscle activation. So in particular, there's damage to the dorso-reticulospinal tract, here shown in purple, either directly or indirectly via the cortico-reticular connection. In addition, stroke can result in damage to the corticospinal tract, the rubrospinal tract that's not shown here, and also the tectospinal tract. So bottom line is, at the spinal level, there's a loss of inhibition due to damage to all the pathways, and leading to hyperactive activity in stretch reflexes in particular, and also a lack of activation, direct activation from corticospinal tract to alpha motor neurons for there to be a strong link between the corticospinal output and the voluntary control or voluntary action. At the spinal level, there's several mechanisms that have been described leading to disordered, again, stretch reflex function. Again, this was designed to describe the origins of spasticity, but it has implications for disordered movement as well. So initially, early studies of Hagbarth and Falbo tried to find an origin of the excessive muscle spindle activation because of gamma overactivity. But in fact, that was found to not be supported by later evidence. There are, however, changes in motor neuronal properties that result from altered afferent input. The evidence of this is the presence of persistent inward currents, which have been described by C.J. Heckman, leading to development of plateau potentials that amplify the inputs to motor neurons, and this results in persistent firing and increasing the reflex gain. These altered mechanisms have been well described in people with spinal cord injury, but so far a bit inconclusive in terms of people with stroke. So we can't assume that all upper motor neuron deficits, lesions lead to similar deficits, and they are very specific to whether the deficit is spinal or central in origin. There's also changes in properties of the synapse, such as decreased presynaptic inhibition, mainly described in spinal spasticity, decreased homosynaptic inhibition, but their post-activation depression has been correlated with spasticity severity in people with stroke. So it's not a very clear picture for one or the other, and people have been trying to understand and separate all these mechanisms out in order to get a clear idea of what's happening in spasticity. So at the spinal circuitry level, there's a lot of changes going on. They're all listed here. And finally, there's also changes in muscle fiber properties. So again, the story in muscle fiber properties is not that clear. There's no agreement about whether there's an increased percentage of type 1 fibers or a decreased percentage of, or an increased percentage of type 2 fibers, or whether or not there's even a change in the fiber type distribution. And you can see there's a lot of different people who have come up with different ways of describing what's happening in the after upper motor neuron lesions in terms of changes in muscle fibers and their distribution. So this problem may be related to the methodology used to determine the fiber type distribution. So it might be due to sampling problems inherent in the biopsy procedure that was suggested a long time ago, but it's still very much up for debate. So we have a very clear, or let's say unclear, picture of the origin of disordered motor function and the presence of spasticity. Yet we still have to treat patients, and we do that in rehab, since stroke is the second most prevalent problem leading to the mobility disorders in the elderly. So we also know that up to 85% of subacute stroke patients have arm sensory motor deficits that persist into the chronic stage, which is greater than 3 months. So there's been much less effort, actually, from a rehabilitation perspective on rehabilitating the upper limb. This is because hospital stays are very short, and so the objective of the system is to get the patient as mobile as quickly as possible and get them home. So to do that, the focus is on the lower limb. And oftentimes the upper limb is neglected and not treated at all. Yet, upper limb activity is certainly very important for having a good quality of life. So we have tried to identify effective upper limb interventions after stroke, and people have used different models of rehab interventions using robotics and using virtual reality and using a lot of feedback and using forced use paradigms and so forth. What we do know is all of these studies know whatever we do leads to better upper limb mobility outcomes, but there's no way to differentiate one treatment. No one treatment is better than another. And in fact, we know that even the idea of doing more is not enough. It's not just doing more that's important. So it's not just more practice is better, but it may be, and I think a very important point, that is related to the type of movement training that we're doing. And I think we have to be much more impairment-based and individual-based in order to identify what the problem is in that individual and focus more on their deficit. But for that, we need to have a good understanding of what is normal motor control. And I'm going to get to that in a minute. We know that when we do just more practice, which is the usual procedure, thinking that more reaching practice will lead to better reaching, in fact, is not necessarily true, because we know that practicing the wrong movements can lead to maladaptive plasticity. And Teresa Jones in her group, she's an animal stroke researcher. She's done an amazing job in looking at what's happening in the reorganization of brain pathways in animal models, and now has actually started looking at clinical studies in patients with stroke. And she's shown that if we allow the animal to compensate, in other words, to find other ways to make an action that may not be considered within the normal realm of normalcy, which whatever that is, but if we allow the animal to compensate, we actually can limit the recovery of more normal movement patterns and more functional use of the paretic limb. So this is a very important observation, and it really helps to settle this debate of whether we should let patients find their own solutions or whether we should insist on trying to find the more, let's say, optimal or more effective solution. That's a debate in the rehab community that's very ongoing, but I'm not going to get into more details now. So I think an essential question, and especially for the rehab community, is that motor recovery, or what we consider recovery, is based on our assumptions about what constitutes normal movement. And we know that because of redundancy, and for this group, it's we already know this quite well, that because of redundancy and the phenomenon of motor equivalence, there's many different ways that a normal movement that can be performed, and all of these movements are acceptable solutions to the motor task. So Mark Latache has argued that all motor solutions are acceptable if you arrive at the right task solution, and that it is true more true in the normal in the undamaged nervous system, but it could be a problem in the damaged nervous system, as I already mentioned. So motor behavior can be broken down into two levels, and here, of course, we know this very well. That with kinematics, we can look at behavior of the endpoint, and what we call the performance level, and behavior of the joints and contributing to the endpoint movement, and we call that movement quality level. And again, this is more for the rehab community, that we should realize that just doing a movement faster doesn't necessarily mean that movement was done better. So just to remind you of the degrees of freedom problem, if it's, or maybe we should change this terminology, but is there a degrees of freedom problem? We know from Bernstein studies and many other studies that movements never repeat themselves, but that every time we move, we find a unique solution to the redundancy problem. So if a person wants to touch their nose with a limb that has 7 degrees of freedom, this 7 degree of freedom limb does not include the 3 additional degrees of freedom in the scapula, and doesn't include the 27 degrees of freedom in the hand. So just the 7 degrees of freedom becomes a really big computational problem to try to figure out how these movements are done. But we also know that we can do this movement using a variety of solutions, and all of the solutions are acceptable if the task is done correctly, to touch the nose. So the problem of redundancy may be termed abundance, as Mark has done in his 2012 paper, and as he mentioned in his talk. So we have an abundant way of solving the problem. Another example of abundance is this. So this goes back to the Bernstein experiments that were done at the early part of the 1900s. And as Mark described already, they had light bulbs on the limbs, and they took fast frame photography, and they reproduced the kinematics. We repeated this experiment with Julie Cote, and the task was to hammer a target with repeatedly with a hammer, and then we fatigued the shoulder muscles and repeated the hammering. You can see that this is just the trajectory of the hammerhead. It's not even the hand or the limbs. But you can see that there's a lot of variability in the trajectory, and if you look at the 2D representation in the vertical and anterior posterior direction. And that, however, what the system is stabilizing is the direction of the hammer strike, so the orientation of the hammer with respect to the pad, and the relative location of the hammer strike on the pad. So this is preserved in spite of the variability in the hammer trajectory. And the hammer trajectory variability is due to variability in the upper limb joints that are contributing to the movement of the hammer. When we fatigue the shoulder muscle and actually take shoulder flexion out of the movement pattern, which I don't show you here, you can see that the trajectory is changed, but the endpoint or the task variable is preserved. Stability of the task variable is preserved. So this is just another example of the abundance, and the abundance allowing us to adapt our movements in the case of fatigue. Okay, so let's look at people with stroke. For some tasks, sorry. Hope it'll stay there. All right. For some tasks, the variability at the end effector level in patients with stroke can be restricted compared to healthy subjects. Now, this task was done with Pavel Mikhalchev quite a while ago, but the task was to hold onto a handle of a manipulandum that had an isometric force either pushing on it or pulling on it, and then that force was suddenly removed in different directions. So if there was a pushing force, and then there was a pushing force, and the person had to stabilize the hand in that position, and then the load was suddenly removed in 3 different directions, and the instruction to the subject was, do not intervene. Don't do anything. So don't hold the hand in that position, just let the arm go where it wants to go, okay? So we did that for pushing and for pulling. And there's, if you look at this is the endpoint or the hand trajectory when the load is removed in different directions. And you can see there's a nice spread across the workspace in the pushing direction. In the pulling direction, there's a little bit of restriction due to the biomechanical restrictions of external rotation extension of the elbow. But there is still more variability in the healthy subject than in a person with mild stroke. And if you look at this person with moderate stroke, you see that they're defaulting always to the same pattern. So they have no variability at all, and their movements end up going into some kind of what we call abnormal synergy. So this is an example of endpoint where there should be variability, there's less variability. And in other examples, we have the opposite case. So let's look at how we use different degrees of freedom to reach. In this example, we have an example of a person. It's a top-down view of the shoulder. Here's the shoulder girdle. There's the sternum in the front, the right shoulder, left shoulder, elbow, wrist, and hand as fingers. And the task is to reach forward to touch the object located in the midline or an object located in the ipsilateral space. So the dotted line is the initial hand position. This dot should be up here, sorry. Anyway, this dotted line is the initial hand position. The dashed line is the configuration of the arm at peak velocity, and the solid line is the configuration of the arm at the endpoint. So the task is to reach forward, and you can see that in the healthy subject, the person has no trouble moving the arm. Of course, this is a target that's within the arm workspace, but the mildly affected stroke patient and moderately affected stroke patient show a change in the kinematics, whereby there's an increase in the amount of trunk rotation, even in the mildly affected patient for the midline target. And for the moderately affected patient, the task is actually done correctly. The hand actually reaches the target, but it's done without any elbow extension at all, and shoulder adduction. In fact, all of the movement here is done by the trunk. So the system reorganizes itself using its available degrees of freedom in order to achieve the task. The task is achieved, and that is so the goal is actually achieved, but through different means. When we look at what's happening here, this is a top-down view of the endpoint trajectory from the initial to the final position here for 3 different targets and how much trunk movement there is. Just ignore the red traces. They're from a virtual environment, and that's for another topic. But I just wanted to show you that for the healthy subject, there's a certain variability in the endpoint trajectory that we find normally in healthy people. And in the stroke patient, you also see some variability. You see some imprecision and uncertainty at the end of the reaching, even in the mildly affected patient with stroke. But notice here that the amount of trunk displacement is much greater, as we just saw before. And in fact, most of this hand trajectory is actually performed by the front movement. So let's look at the system. So getting back to the idea of compensation, one of the major compensation used in patients with stroke when they're reaching is the trunk use. So we should understand how the trunk is being used to compensate for reaching, and then how we as therapists can effectively reduce that compensation and improve movement. So in this experiment, we actually looked at the influence of the trunk on the hand movement. So we had people sitting in a chair and reaching for targets located at 4 different distances from the body. So close to the body, so well within arm reach. In the second reach, they reached to the limit of arm extension, so comfortable reach distance. The third example, they reached beyond comfortable reach distance, so they had to move their trunk forward. And in the fourth reach, they reached, the target was actually at 2 times that length, so they actually had to sort of squat or stand up and involve a lot more degrees of freedom to do that reach. When we plot the amount of movement, amount of hand displacement due to displacement of the joints of the arm compared to displacement of the trunk, for reaches in healthy subject, for reaches to the first and second target, essentially they're not moving their trunk at all, so the line is vertical here, and you can see that only the arm is contributing to the movement of the endpoint, arm joints, sorry. But for target 3, the trunk starts to be recruited. You can see the line is slightly sloped, so the trunk starts to be recruited, but right from the beginning of the reach, and up to a certain point, and then the trunk is recruited a lot more because we've reached the end of the limit of extension of the arm. And this is true also for the target 4. So the trunk is recruited right from the beginning of the reach and a little bit more towards the end of the reach. This pattern is preserved in people with stroke, with mild stroke, but it's disrupted in people with moderate and severe stroke. And in fact, the lines are a lot more sloped, meaning that if we took the slope of this line of reaching to the 4th target, where the target is obviously beyond reach, and the trunk obviously has to be recruited into the reach and is recruited early in the reach, we have the same slope actually for reaching to a close target. So this implies that the person is already perceiving this target as being beyond the reach, because the trunk is being recruited right from the beginning as if the target was beyond the reach. Let's look at the timing of the trunk movement. This is a study by Ma and Feldman in '95, whereby they looked at what was the timing of the trunk and endpoint recruitment when reaching with the trunk moving in the same direction. So a trunk assisted within reach. So it's a within reach, trunk assisted reach, meaning that the trunk is moving when the arm is moving to the target, and when the trunk is moving in the opposite direction to the arm movement. So when the instruction to the subject was move your trunk forward or use your trunk to help you reach, the trunk is recruited. You can see the dotted line. The trunk is recruited temporally before the hand starts to move and continues to move after the hand stops moving. So trunk is recruited before hand movement onset and continues moving after hand movement stops. Similarly for in-phase and for out-of-phase movements. So this is the normal pattern. It's been shown repeatedly in many, many studies, and studies by Kaminsky and his group, as well as Feldman and his group. When we look, so we looked at people with stroke. So here's, in this picture, we are looking at when the trunk starts. The line that starts before the midline means that the trunk started moving before the arm. And if the bar is on the right side, it means the trunk ends after the arm. If the bar stopped in the middle, it would mean that both were simultaneous. So the healthy subject, you can see this pattern where the trunk trunk recruitment starts before the arm and ends after the arm stops moving, and the same pattern is preserved in patients with stroke. So temporally, there is no difference, but spatially there is. So we think that using the description of critical arm distance of Mark from 1997, Mark described that there's a critical arm distance beyond which the object to be reached is perceived as being reachable. It's about the affordance of the object. So if the target is located beyond the critical arm distance, then the system already knows to recruit additional degrees of freedom in order to reach that target. So we think that the critical arm distance, which is a perceptual, it's a basis for perception action coupling. So this critical arm distance, we think, is actually decreased in stroke. So it's not just a question of not being able to get the elbow extended enough to reach the target, but it's also that maybe the target is being perceived as being beyond the reach. And maybe we should work on perception in order to push that perceived distance further out. So this is important for retraining of reaching tasks in people with stroke, but it's also very important when we consider or when we create virtual environments for training patients, that we are aware of the perception of the relationship between perception of object distance and formation of the reaching synergy. Okay, so just to summarize this part, I'd like to say that patients with chronic stroke use excessive trunk movement even for reaches to close targets. And I showed you an example of assisting hand transport during reaching. We also have studies showing that trunk movement is used to assist in the orientation of the hand for grasping, especially when there's a problem with coordination between wrist extension and elbow extension in order to create a correct hand aperture. We also have studies showing that the trunk is used for assisting arm swinging in standing and during walking. So upper limb articular redundancy is decreased in patients with stroke, and for simple reaching, when the trunk is involved, it is recruited as an integral part of the reaching movement. So I see there's some questions. Are they related to this section, Mark? And should we stop or should I continue? In the chat. Should I take the questions myself?
No, I think you can take them at the end of the talk, so you don't have to interrupt yourself.
Okay.
Yeah.
Okay, great. Okay, so let's now ask, does this limited abundance that we see in patients with stroke affect their motor adaptability? So here we are focusing on understanding reaching from the perspective of motor equivalence, which is part of the theory on which the referent body configuration hypothesis is based. So I'm going to go through a description of how we think reaching is produced in the referent body configuration hypothesis. Anatoly, you can jump in at any time if you want to refine or discuss. So in the initial position, let's say a person is standing and wants to reach their hand to a fixed target. So a person is standing, and at that initial position, where the referent body configuration is equal to the actual, this Q is the actual body configuration. So the actual body configuration in gravity is equal to the referent body configuration. Then, in order to achieve movement based on the minimization process, the referent body configuration has to move away from the initial position, and then the Q, or the actual body position, has to catch up. And Anatol showed a movie of sit-stand, in which that procedure was shown, where the referent configuration is preceding the actual configuration. when the actual configuration actually does move forward, is also affected by gravity. And so it actually goes a little too far, a little further. And there is a discrepancy between the endpoint position where you end up. But the reference configuration is organized so that this discrepancy leads to the correct positioning of the hand. Okay? So invariance of the actual trajectory, is achieved by the system regardless of the number of degrees of freedom used in the task. The system is not concerned with movements of the shoulder, movements of the elbow, movements of the wrist or the hip. The system is concerned with shifting of the referent trajectory, and the system organizes the different degrees of freedom can be used to achieve that final position. They can vary from trial to trial as long as the actual trajectory invariance is maintained. So based on this idea of referent body configuration change in position and the concept of minimization and the concept of motor equivalence, we set up a series of studies in patients with healthy subjects and in patients with stroke. In the first study, we looked at movements or reaching movements from a sitting position in 2D space. So the subject was sitting in a chair with a electromagnet attached to their back. There was a reach to a target that was beyond the reach, slightly beyond the reach of the arm in the ipsilateral workspace, and they wore opaque glasses. So this task was done without vision. We didn't want the person to be able to see what they were doing because we didn't want them to make corrections. We wanted to see what would happen when we suddenly decreased or changed the number of degrees of freedom and we wanted to know whether the referent configuration was invariant or the actual configuration was the same as the referent configuration. So I should repeat that. We wanted to see whether the actual trajectory was invariant in the two conditions. So let's look at what happened. So either the person could reach with the trunk moving forward at the same time, which you see here, the trunk is moving forward, and with the red trajectory, this is the hand trajectory. That's the hand trajectory associated with the movement where the trunk was free to move. When the trunk was blocked, as shown by this little black line, you can see that the endpoint trajectory is invariant. It is staying right along the same as the free trajectory, even though this is done with a different body configuration. And there's a little deviation at the end when the hand reaches the limit of the ability to extend the arm. So this pattern is very robust and shows that the subject is interested, or the task goal is to keep the referent trajectory invariant, regardless of the condition or how many degrees of freedom are involved. In the patients here, the two shown here, this patient is very, very mild with a 60 out of 66. Practically no symptoms of stroke left, but you can see that there still is an early deviation of the actual trajectory when the trunk was blocked compared to when the trunk was free to move. And in the patient with mild stroke, 50 out of 66 is considered mild, there was an obvious, again, early deviation of the two endpoint trajectories. These are means. So there's some problem here in organizing this. But how does this endpoint invariance achieved in the two conditions? We think that there's two synergies or two configurations, referent configurations. One referent configuration moves the hand from the initial position to the final position. Call this maybe the arm reaching synergy. But the second one takes into account that the trunk is moving forward and actually compensates for the forward trunk movement by moving the hand backward to an equal amount. We think that these two are superimposed on each other. So the superposition of the two reference shifts lead to the synergy that stabilizes the endpoint trajectory and allows us to keep the hand trajectory invariant. Looking at how the person achieves this invariant endpoint trajectory, we can see that when we look at the coordination between the shoulder and the elbow, shoulder flexion and elbow extension. So one coordination is illustrated here by the dashed line. This is the one where the trunk was not blocked. The trunk was free to move. And you can see that this is one coordination, but when the trunk is blocked, there's another coordination. So this is an adaptation of the two coordinations from the two conditions. This adaptation allows the person to maintain the trajectory. All it shows is that the person adapts the interjoint coordination in order to maintain the hand trajectory. The patients with stroke had some difficulty with this task, and you can see that there is no clear deviation or separation between the two interjoint coordinations. So they got really kind of stuck into this pattern of shoulder flexion, elbow extension. They're unable to change the pattern rapidly to the conditions of the experiment. And therefore, they were unable to maintain the invariance of the endpoint trajectory. So there's a limited number of synergies and the ability to adapt the synergies.
Can I ask a question?
Sure.
So you say that there could be simultaneously two referent configurations at the same time. I thought that the reference configuration was a whole body configuration. So if you say there are more than one, maybe two, maybe 10, maybe 100, so then you have a degree of freedom problem of all your referent configurations, or is there something that I don't understand?
Well, I think this is something that we can address at all. But certainly not all tasks are simply made by one single reference shift. And some tasks may need, for example, in this case, it seems like there may be two that are superimposed on each other. I don't think that Anatole has extrapolated that to hundreds. I'm sure there are not. But certainly this is something that needs further investigation.
Just briefly, why would be there only two then? There shouldn't be any limit then. I'm just wondering anyway.
I think there would be. I think this is a good experimental question. We don't know, okay? I mean, theoretically, if you have a single task with a single goal, there may be only one shift. But if there's several things going on during that, there may be two happening simultaneously or in a coordinated way or superimposed or something. I mean, certainly in the concept of movement, we don't all move in one single gesture all the time. Other things are also going on. Okay, so I think we should be open to the idea that there may be two happening simultaneously, coordinated in some way, which seems to be a simple way of describing this task, especially for the reaching. But, this is also a very experimental condition where we artificially get somebody to sit in a chair and reach. And, it's not something this is not really a very functional everyday thing. We don't do that right like that. So when you start manipulating things, then you can control the conditions and look at how what may be controlling that.
So then maybe the second referent configuration emerges from a injured nervous system, but would not exist in a fully functional one?
No, on the contrary, I think the second referent configuration is necessary in order to do that task. But it may not be. What we're saying here is that maybe that fine mechanism of superposition is not possible or is diminished in the patient with stroke, and they're not able to rapidly adapt to the new condition.
Well, maybe I can add a little bit to this discussion, because it seems like we we are talking about reference configurations now very freely without really defining what we mean. So reference configuration to me, or reference coordinate, is reference coordinates for the task-specific important variable. Then they map on reference coordinates for elements. And for example, the elements may be the trunk and the arm. And this mapping may also has an intrinsic stabilizing mechanism in it. So one can consider, after that mapping, one can consider two components of the action. One of them is the reaching movement of the hand, and the other is the combined movement of the trunk and the hand. And then, well, one of them can malfunction in certain groups of patients. But I think that before we start counting the number of reference configurations, we should state whether we are counting at the task level or we are counting at the level of elements, even large elements that all contribute to the task.
Right. I think that's a very good point. I think here we're talking about task level reference configuration, I think. But it is an open question and certainly needs, we are continuing to look at different tasks and different examples and trying to understand and unravel all that. Okay? Should I move on?
Fine,
okay.
Fine. Yeah.
Okay, right. Okay, so that was an example in 2D space. Now, recently, we repeated this experiment with Fariba Hassan Barani, a postdoc of mine and former student, I think, of Mark, whereby we did the task of reaching in 3D space, again, with the same protocol, where there's free trunk reaching, and sometimes there's an electromagnet that suddenly blocks the trunk. It's blocked before the person even starts to reach, but simultaneously with the beginning of reach. And again, without vision, so there is no corrections. So here the task involved trunk movement forward while the arm is moving sideways. And here again, in the healthy subject, we see the invariance of the trajectory when the trunk is free to move, the blue one, and when the trunk is blocked, the red one. Here, in order to achieve the invariance of the trajectory, the person had to adapt to at least two. We only looked at two sets of interjoint coordinations. So shoulder abduction and elbow extension, shoulder flexion and elbow extension. This is two of possibly others because there was also rotation of the shoulder. There also may have been supination of the wrist, of the forearm. So we're looking at two out of several coordinations. But both of these adapted in order to maintain the endpoint trajectories invariant. Stroke patients showed deviation, early deviation of the two trajectories. You can see the summary diagram here that the divergence point, which is where these two trajectories diverge, occurred earlier in the whole group of patients, and they showed an invariance in their interjoint coordination. And in other words, an inability to rapidly adapt the interjoint coordination to the changed condition. This is for exocentric reaching in 3D space, and we had also the same paradigm, but for egocentric reaching in 3D space. So this is quite a different kind of reach. The person has a rod attached to their forearm, and they have to reach along the arm. So you're basically reaching within the space or the configuration of your own body. And when the trunk is moving forward, that configuration doesn't change. The whole thing just moves forward. So there shouldn't be any difference in the endpoint trajectories or in the interjoint coordinations when you're doing the egocentric reaching according to this setup. And in fact, we didn't see in the healthy subject any deviations. So there was a clear invariance of the endpoint trajectories, Invariance also of the interjoint coordinations for both of the combinations. The stroke patients had difficulty. This is one example, but it was clear across all the subjects. The stroke patients had difficulty maintaining the invariance of the endpoint trajectory, and this was again because they could not nail or keep the same interjoint coordination. So this problem of stabilization of the endpoint trajectory is appearing for 2D reaches, 3D reaches in egocentric and exocentric space. What about reaching from standing? Here we go back to the example I showed at the beginning to describe the reference shift. So we did this with from standing, a reaching from standing paradigm, but instead of just perturbing the trunk, we perturb the whole body. But when you're standing and you reach forward, your buttock has to move back. You're flexing from the hip, and your buttock has to move back. So in the free hip condition, that occurred. But in the blocked hip condition, we had an electromagnet that could be held steady, or it could be at when it was active, it stopped the buttock from moving back. And that's the same thing as giving a person a perturbation forward, and it caused the person sometimes to take a step. We compared that condition to an intentional step condition to see whether this was in fact different from the perturbed condition. So these are all randomized. Again, this was done with eyes closed to a remembered target, and it was the target was placed at 130% of the arm's length. So this is I'm going to show you what was preserved in the task. Again, is the endpoint trajectory. So this red line is the endpoint trajectory of the unperturbed reaching condition. This is the interjoint coordination between three joints, shoulder, elbow, and hip, in the unperturbed condition, and the endpoint velocity time profile. This is the initial body configuration. So when the healthy subject moved with the perturbation, there's the perturbation, here's the step. The system is preserving the endpoint trajectory quite well, and it did. Even the endpoint velocity was preserved. What was changed was the interjoint coordination. So the person is able to adapt the interjoint coordination instantaneously to the conditions of the reach when the perturbation occurred. Here's a patient with stroke. Now, just understand that in order to do this, these patients had to be pretty mild, okay? So these patients are out in the community and have very minimal symptoms. Yet, when they do this task, again, this is the endpoint trajectory of the unperturbed condition. This is the interjoint coordination of the three, okay? So here's the reach. Here comes the perturbation. There's some deviation. There's a late response, actually, a stepping response, and a total loss of control at the end. And there's a person's unable to keep the hand in the final position, despite due to the change in the into the number of degrees of freedom that were involved. And you can see again, they really didn't change their interjoint coordination very much. So they're stuck in this pattern, even though they're really well recovered, they're walking around, they're probably back at work, yet they still have this problem of handling perturbations, probably because the system can't reorganize according to the available degrees of freedom, or it can't, I think we're having a problem with the specification of the referent body configuration. So this is just a static picture. So healthy subjects preserved the endpoint trajectory despite changes in trunk and leg displacement, whereas there was deviation in the stroke patient. There was always an overshoot error, and in the conditions, and again there was of course differences in the leg and trunk displacement. What's interesting here is this picture. So this is just a interjoint coordination picture between elbow flexion, shoulder flexion for healthy, mild stroke, and moderate, and hip flexion, shoulder flexion. These are pretty straightforward coordination profiles. But I just want to you should pay attention to the red lines. So the red ones are individuals who showed abnormal patterns. So their interjoint coordination pattern deviated from the mean of the group and of the normal of the healthy subjects. These are the coordination patterns when there was no perturbation. So in the unperturbed condition, a number of patients with moderate stroke showed a different interjoint coordination pattern between elbow and shoulder already, and fewer of them, of course, in the mild stroke. But these individuals also then had much more trouble in the changing or adapting to the perturbation when that occurred. They showed less adaptation. So we think that this is probably linked to their initial ability to do the reaching or the initial reference shift. So I'm going to go now to try to explain why we think all of this perturbation, why people are having trouble, patients have difficulty with specification of the referent body configuration. So we think that kinematic redundancy may be limited if part of the restrictions in the range, in part by restrictions in the range of regulation of thresholds in patients. So range of regulation of thresholds, what do we mean? So Anatol described this a little bit in his talk, and he talked about the origin of lambda. So when we look at the lambda with respect to the biomechanical range in which lambda is regulated, we get this kind of picture. So PSRT is the tonic stretch reflex threshold, can also be called lambda. Lambda in a muscle, in a single muscle, it's called lambda. And this is a representation of the TSRT in a single muscle. So the range of regulation of the TSRT in a single muscle should extend beyond the actual biomechanical range of the joint in order to be able to specify any torque at any joint angle. So this is a representation of the threshold of the muscle, okay, at rest. So the system's at rest. This is the torque angle characteristic, or the biomechanical torque angle related to that initial, related in that muscle at that position. So in order to cause a movement, the person has to be able to shift that torque angle characteristic anywhere within the biomechanical range in order to specify any torque at any joint position. We think that there's a limitation in the range of regulation of thresholds in patients with stroke, in which patients can manipulate, and that these are thresholds are restricted in terms of where they are at rest. So instead of being outside the range, the joint range at rest, it's actually resting inside. This would be the threshold for the flexor muscles, and then maybe restricted also in how far it can be pushed in this direction, or even further restricted by what's happening in the antagonist muscle, but I'm not going to go into that right now. So in the range where there is the capability of the patient to regulate the threshold, they should be able to actively control the muscle, and we call that the active control zone. But any point to the right of the upper limit is called the spasticity zone, because it means that at rest, the muscle will show abnormal activation. The muscle will start to be activated at this joint angle, and the activation will increase as the joint angle increases. In this zone, if there's a lower limit of the regulation, that would be evidenced by marked weakness in the muscle. This is a completely different way of looking at motor or movement deficits or muscle deficits than the traditional way, which just approaches this from a very direct way, saying if a muscle is weak, you just have to strengthen it. So according to this, strengthening the muscle is not going to make much difference. What you have to do is change the range in which muscle strength can occur. So if the sorry, I lost that. So we can't measure the threshold in an actively contracting system, right? At least we haven't done that in patients with stroke. We've only measured the threshold at rest. And we do that by stretching the muscle at different speeds, and then measuring the velocity and the angle, especially the angle at which the muscle activation starts. So in a healthy subject, when we stretch quickly at a high speed, we should be able to, we may or may not see a response at a long muscle length. But in a patient with stroke, when we stretch faster, we get an earlier onset of the muscle activation. So we stretched using a torque motor. We did 50-degree passive, or 50-degree stretches of passive elbow flexors and extensors at 8 velocities ranging from 8 to 160 degrees per second. These are relatively slow stretches. So 160 degrees per second is going through the full range in 1 second. It's pretty slow. Yet we still get a lot of responses in patients with stroke. In healthy subjects, there should be no responses at all at these speeds. We did 10 trials and per velocity and randomized that, and looked at the activity in 4 muscles, 2 flexors and 2 extensors. And then we also asked the subjects to make very slow, quasi-static movements into full flexion and then full extension. And we looked at the muscle activation patterns throughout the joint ranges. So this is an example of a stretch, a velocity, a bell-shaped velocity stretch, moving the arm into extension. This is the movement and the onset of the activation in the abnormal activation in the biceps and the 2 flexor muscles. And we looked at the angle and velocity at which that occurred. And then we stretched again at a different speed and again took this pair of values and we plotted them on a velocity angle curve and extrapolated that regression line through those, what we call dynamic stretch reflex thresholds, to the static one. So what would be the tonic stretch reflex threshold at 0 velocity? Okay, so this is the value of the TSRT. Here's an example of what this looks like in one patient with stroke, where we looked at the profile or the TSRT in the flexors of the elbow, and this is the TSRT in the extensors of the elbow. You can see that there's quite a bit of area. Any area to the right of that line is related to the appearance of spasticity. So there's spasticity from this angle onward when the person's at rest. And if you stretch faster, the range of spasticity increases. And this is in a passive sense. Okay. Also for the extensors. So we made profiles of where these ranges were. So the blue line with the blue color there's an active control zone throughout the entire range. There's 12 patients shown here. These are least severe. These are most severe. But this is just to show you and actually to convince my rehab colleagues that all patients are different. So in a group of 12 different patients, or 12 patients with varying severity of impairment, you can find different patterns or different joint ranges in which active control is possible, where control is only possible, or movement is only possible with coactivation, or movement is not possible in one direction or both. And these patterns differ, even in severe and mild. So you can't put them all together into one lump group and then try to make conclusions about them. You have to really separate them by their level of individual impairment. So looking at
small question, just to be sure, because I see on one or few cartoons that there's spasticity at both ends of the at
Yeah.
the far end of the range and at the near end of the range. So in comparison to the explanation you previously gave, how do you explain specificity of the shorter range would be due to the antagonist? Is that correct?
No, yes, yes. So this
Okay.
is agonist antagonist picture. And in order to have an active control zone, you have to have the ability to move in both directions without encountering resistance.
Okay, thanks. Yeah.
Yeah, it's not, it's sorry, I didn't mention that. Thank you for picking it up. Okay. Okay, so
Mindy, can I ask you also a question? For instance, for some pathologies, spasticity is more evident for distal muscles than for proximal. I just wonder, in stroke, whether you found this spasticity zone more, how to say, more affected in proximal or distal muscles. Can you comment on it?
yeah, there are certain joints that develop more spasticity, wrist flexors, ankle plantar flexors, elbow, but there's also the elbow flexors and a lot of scapular spasticity as well. I'm not sure that the distribution is proximal distal or distal proximal. And you can also find people with no wrist spasticity and only elbow spasticity. So I think it really depends on the lesion type. And that's actually a very important question. That can you predict from the lesion type where and how the spasticity will manifest? And then can you intervene with an early intervention prevention protocol to diminish the onset and the gravity of spasticity to improve the quality of rehab, okay, or recovery? It's an important question. We're actually doing a study on that right now, where we're looking at acute patients who have no spasticity yet, and we're measuring them with the TSRT weekly while they're in the hospital and up to 16 weeks post ictal event in order to see where and who develops spasticity. And we're doing quite extensive brain imaging and midbrain spinal cord imaging to identify which patients develop which type of spasticity. It's a very important medical question because we want to predict who will develop spasticity and then diminish the impact of that by early intervention.
A very quick question in the same vein. Is there patients that have only spasticity of the the shoulder and the hip and nothing else, or is that impossible and you've never seen that?
You know, I can't really, I haven't seen every single patient and I really can't answer that question. In my experience with patients, they usually have multiple areas involved. If they have spasticity, it may be more problematic in one part of the body than another, and that's the area that you would focus on. But I can't definitively answer. Sorry.
Thanks.
Mindy, the same question, well, similar, because it's important. You talked a lot before about the trunk control, but if the trunk is used to assist reaching, does it imply that trunk control is less affected by stroke than limb control?
That's a good question. So heavy trunk is affected, yes. It's one side of the body. But because the muscles of the trunk are bilaterally innervated, the effect is less obvious than in the upper limb when you have contralateral only. So I wasn't talking about, well, maybe it was, we weren't there is a population of patients or a group of patients who don't have good trunk control. And this is a whole other group of patients. They are not the ones that we are looking at. We usually involve people who are pretty mild and they haven't They are able to do all the tasks we ask them to do. So we would, but trunk control is usually, there's a hammy problem. One side is weaker. There may be some drift, but essentially people are able to have much better recovery of the core muscles than the peripheral muscles. Okay. Okay. Good. So getting back to our example of this person's, you still see my screen? Yeah. Okay. So getting back to my example, this is one of the people that we saw on the last slide, and we took this profile and we said, well, what will happen if we ask the person to position their elbow at 90 degrees and then to flex within the active control zone? So theoretically, active movement should be normal there. And in fact, it is. So when the person flexes from 90 degrees and stays within the active control zone, you see a reciprocal pattern of muscle innervation, which is absolutely normal. However, the same patient, when you ask them to extend from a position in which they have to pass into the coactivation zone, or into the spasticity, they pass the TSRT for the flexors, you can see they have a very strong activation of the extensor muscles, but they also have activation of the flexor muscles that ends up restricting the movement of the limb. And in fact, you get, this is a bit of extension, and then it gets stuck, and the person can't go any further because of this massive coactivation and inability to continue to move. So this is, people interpret patients who have difficulty extending their elbow as having weakness in their elbow extensors. But this person has no weakness in there. What they have is spastic restraint. So we have to understand the reasons for the movement problems in order to address them properly. So this, in the same person, movements made in the active zone can look absolutely normal, and movements in the spasticity zone quite abnormal. This is just another example of that the TSRT can differ in muscles that have multiple attachments versus one single muscle. So brachioradialis versus biceps brachii, and you can see the thresholds are slightly different. This is the one in brachioradialis, biceps. This is brachioradialis, slightly different by about 5 degrees. So it raises the question of when we're doing a measure, we have to be specific as to which muscle we're actually looking at, because we're only looking at one muscle at a time, and of this very complex system. We've looked at the velocity dependence of the response. So in people who have spasticity, there's a velocity dependent profile, meaning the earlier or the faster you stretch, the earlier the response is seen in the dynamic stretch reflex thresholds in flexors and extensors. But in people with Parkinson rigidity, that velocity dependence is no longer prevalent. And this is indicative of a rigid muscle compared to a spastic muscle. We did a number of studies looking at intra-rater and inter-rater reliability for both the elbow and the elbow flexors and for ankle extensors. It's got moderate to good reliability, but better reliability in lying than in sitting. The MDC is quite high. It's about 32 degrees, MDC 95. That's the minimal detectable clinical difference. Minimal clinical difference. I think there's MCD, it should be. Anyway, it should be at minimal clinical difference. Sorry, messed up the word. So, in other words, what change has to occur in a patient in order to see a change in motor behavior? This has only been tested once. We still have to test this again in different situations. First of all, the question is, can you change the TSRT, and how much do you have to change the TSRT to make a clinical difference? Responsiveness is 6.8 degrees, meaning that after intervention, we found a change in the group by about this amount. So that's really below the minimal clinical significant difference. So we have to do better in our treatments in order to make that make the measure even more clinically meaningful. At the biarticular level, so until now I've only been talking about one muscle, and that's kind of a very sort of looking at the system through a microscope, and that system involves multiple muscles. So at least we looked at the behavior of the spasticity when we looked at two muscles or two joints. So we did passive stretches and active movements of elbow flexion extension, initiated from 3 different arm configurations where we changed the shoulder position. So we had we mapped out the spasticity in elbow shoulder space. So this is what we found in one person, one example. So each these are 3 different people. Sorry, but this is one person. So this is the gray area is the flexor space. This is the elbow angle, shoulder angle space on the horizontal plane. And one space, the spaces are marked, or these lines are marked according to 2 muscles where we looked at the thresholds, slightly differ. But you can see that the gray area is the spasticity in the flexor space. This is the spasticity in the extensor space for this person. And this is another person and another person. You have to basically take these 2 pictures and put them on top of each other. And then you see how much of the arm workspace is affected by spasticity. So most of the arm workspace is affected by spasticity in either one muscle or the other. So what about the C command? We spuriously found this result in a recent study where we stretched the elbow flexors in a large number of people. We had 33 patients with acute to chronic stroke. But we found that 29 of these patients had concomitant activation of the antagonist muscle that was shortening while we were stretching the flexor muscle. So normally we shouldn't see anything happening in the antagonist muscle. It should look like this. But a large proportion of the patients had activity in the extensors at rest. And when we looked at the timing of that abnormal triceps activation and duration, it wasn't necessarily tightly linked with the stretched biceps. Sometimes it occurred at a delay, sometimes it occurred almost simultaneously, and sometimes it even occurred before. So how do you explain this? We explain the onset of the spasticity in the agonist as the location of the TSRT in that muscle. But and that's here. So the onset of the spasticity is the onset of where the TSRT is in that muscle. But we think that maybe the TSRT of the extensors also lies abnormally within the joint range at rest, and it could account for the presence of activation of the extensors when we're stretching the flexors. And in addition, this is not fixed. It could be variable from one patient to the other. So this requires a little more investigation, where we may be able to manipulate a little bit the experiment in order to investigate the behavior of the C command at rest.
Another question, maybe too vast, but anyway, tell me, maybe we can answer later or Wednesday. Presumably with strokes, patients are affected could be affected at all levels, A, B, C, D, E. Do you have any ways of differentiating if there are impairments at all these levels or not? And for example, with patients that are asked to do a movement mentally even if they don't move at all? Is there any evidence of that? Just and maybe you don't have the answer, but I'm just asking this. And also, do all the disruptions at the B level, would they be at the synergy level? Would they be caused by the A level, and you don't need to worry about the B level? So do you have any thoughts about that?
Roger, AB, are you talking about Bernstein's levels? What
Yeah,
level?
Bernstein's level. Yeah.
Ah, okay. That's a very broad question. I don't think I can directly address it right now. But can you write it? And maybe it's something we can address on Wednesday, because it really would require a little bit of thought. It sort of goes a little bit beyond what I'm doing right now. Okay.
Okay. No problem. But in a sense, you're telling me that when you evaluate currently the patients in 2021, you don't necessarily go through a checklist of level A, B, C, D, E, basically what I understand from your answer.
Well, that's true. Okay, so from a clinical perspective, it could also not be true. So we do measure deficits at many different levels, including C and E. Okay, so A is the lowest level and the higher level, and we're getting to higher levels as you go down. So C level is coordination, and then E level would be more ideation. We measure cognitive deficits, we measure things like executive function, motor planning, and all that, but not explicitly. Maybe we measure them, but not because they're listed as A, B, C, D, E. But I think we do. We may address it. Okay. Anyway, I think I need to move on. Yeah. All right. So in summary, threshold control as an output of the equilibrium point theory may provide a means by which we can understand underlying mechanisms of motor deficits related to problems of movement and stability, and we can measure them. And I think that's the key here, that we have a nice, clear way of measuring the deficits. Disruptions in the descending and the spinal systems lead to limitations. I think we've shown that lead to limitations in the specification and regulation of TSRTs and in the specification of RNC commands, and the appearance of spasticity, weakness, abnormal muscle activation patterns in specific joint ranges. So we think that limitation in TSRTs may explain the limitations in voluntary control in specific joint ranges that lead to the recruitment of additional degrees of freedom and the idea of motor compensation. So we're going to go through we have a little bit of time. I'm going to go through a few examples of how we've used the TSRT to understand movement deficits. We used a one-trial learning paradigm to identify whether or how, with the introduction of a change in load, and adapt to that change in load during movement from one trial to the next. It's called the one-trial learning paradigm. So we did an elbow extension task. It's planar joint task, very simple movement, where they had to move from a 3-degree target to a 6-degree target as quickly as they could without making any corrections. And then there were blocks of 8 to 10 trials in each condition. And then after the random number of trials, let's say without a load attached to or pushed against the arm, then suddenly we added a load. So suddenly there was a switching. So there was a load introduced. And they had to adapt in the subsequent trials to do the same rate with the load. And then after a random number of trials, we removed the load. And they would make an overshoot error and then adapt in subsequent trials to reaching again with the load removed. and we kept flipping it back forth and forth, okay? So the patterns were identified like this, that if there was, the person was training to reach the target, this is the target in the dashed lines, without the load, and then suddenly we added a load in the test trial, T, there would be an undershoot. But in the first trial, after the test trial, if the person adapts their movement to the load, in other words, if they shift their characteristic a little further forward along, then they can reach the target with the load. So this is actually an example of one referent shift, and this is an example of a second reference shift. So there's only really two reference shifts that a person is playing with in this task. Pattern 2 is that took more than one trial to learn the second reference shift or do the second reference shift. Pattern 3 is they did achieve they got their hand into the target, but they weren't consistent. And pattern 4 was nothing was consistent. So we identified these patterns in the healthy subjects, the response patterns in the healthy subjects and the stroke patients. So in a healthy control subject, we saw the pattern shifts that were pretty robust. So here the black trial or the darker trials are the loaded ones. Then there was a sudden removal of a load, an overshoot. It took 2 trials to get back into the target. Then there was suddenly the introduction of the load. There is an undershoot. And then only 1 trial to get back into the target. Overshoot, undershoot. Basically, 1 or 2 trials. This was shown years and years ago by Doug Weeks, and then again by Newman Don-Coase. And we repeated this now in another experiment with Sandeep Subramanian. But in the stroke patients that we found, patterns were not so consistent, that their one trial learning is not evident. So can we interpret this to mean that there was a problem with motor learning in the patients? Normally you would say yes, it took them a longer time to adapt to the load. But we made a little trick here. So this is the movement from the initial target to the final target. The black trial is the control trial, or the trial where the person has adapted to the load. And then the load is removed. And the first trial, this is the trial with the overshoot. There's a correction. This is the second trial without the load, and it's boom, back in the target. Okay? So the person adapted after 2 trials at P1. We did the same task in the patients with mild stroke and moderate stroke. And here we put the zone of the targets in range. So in other words, we actually went beyond the TSRT. So they had to move into the spasticity zone, actually, to reach this target. When they did that, we see a lot of disruption in the movement. But in the same people, when we move the target into the active control zone, so we take into account the zone in which the movement was made, movements become a lot more normal looking. Same people, this is random, this is sometimes they got this condition first and that condition second, and or vice versa. There was a 2 to 3 week washout period between sessions so that there was no learning. So essentially, this is the picture I showed you before, where there was 1 trial learning in the healthy subject. There wasn't any real learning in the person in the stroke patient, when the target was located anywhere. So in the zone in which spasticity could occur. But the same patient, when we did the experiment, when the movement was restricted only to the control zone, we see a behavior that looks completely normal. So the conclusion here is that we have to be careful when we interpret studies that are claiming that patients are not learning in a normal way, but it could be just related to where the task space is in which that person is being asked to move. Okay, and in another experiment, we wanted to see if active movement, there's always a big question in rehab, how the measure of spasticity in the passive sense you can measure something passively, but really what's important is whether that spasticity interferes with movement. So we looked at we evoked the TSRT passively by stretching the flexors. See that here, and we identified the threshold in the brachioradialis. But then we asked the patient to actively extend their arm. When we did that, we looked at where the spasticity or where the antagonist muscles started to occur. And that's we call this the active stretch, and we measure the TSRT there. It also, this is one example of the velocity angle profile and the TSRT determination for the BB and BR biceps and brachioradialis in one subject during passive stretch and during voluntary motion, again, passive stretch, voluntary. And you see there's a delta, there's an extension. So in voluntary motion, the location of the TSRT was shifted to the right. And this occurred across all the subjects and occurred also when we stretched the extensors. There was no correlation between the location of the TSRT in the zone and the patient's level of impairment. But there is a correlation between the ability of the patient to modulate the TSRT in the elbow flexors. So the people with less clinical impairment could modulate that TSRT more. That's a very positive result. And it means that adaptability is related to maybe related to modulation, the ability of the patient to modulate the threshold. Maybe this should be our target of therapy. In another experiment with Daniele Piccitelli, who's here, we wanted to see whether the corticospinal system is involved in threshold position resetting, in intentional movement of the elbow in healthy subjects and in those after stroke. So if the M1 directly controls EMG output, then the MEP would be similar at two positions. So here we put the arm in two different positions, on a manipulandum, extended and flexed. We did it passively or actively. And we equalized the EMG in these two conditions so that the background EMG was the same. We only looked at the EMG that was changed, or the response, the muscle activation that was changed due to the active change in position or the passive change in position. And we did a TMS pulse. So this was done in 17 healthy adults and 27 patients with stroke. So if the two positions result from two different reference configurations, and if the EMG is equalized in the two positions, then if the MEP is different, it means that the M1 would be involved in TSRT regulation. We studied this to see if this was affected by stroke. So we can see here that in healthy subjects, the MEP amplitude is modulated, whether in the two different positions. In other words, it was different in the two positions, and is not in people with moderate stroke and severe stroke. These patients had difficulty modulating the MEP in the two positions, likely due to through corticospinal influences. Also, the ability to modulate the MEP amplitude was strongly correlated with the level of sensory motor impairment. The more impaired the patient here, the less difference between the size of the MEPs. And this is showing impairment both at the movement level and at the what we call the spasticity level. And here is another showing that the modulation of the MEP was occurring normally or similarly to the healthy subjects when the movements were made within the active control zone, but they were completely suppressed in the spasticity zone. So the results suggest that TSRT modulation is related to corticospinal excitability, and it may actually provide a link to the observation of spasticity, which has been a very hotly debated question in the area of spasticity, understanding the origin of spasticity in patients with stroke. So in conclusion, overall, I think our data has shown that the motor plan is preserved in patients when they're reaching, in those patients who are not apraxic and don't have lesions in the in basal ganglia or cerebellum, because these were not studied in our studies. But problems arise at the motor execution level, at the regulation of the thresholds, the TSRTs, that cause disruption in individual joint control, and coordination and stability, leads to excessive endpoint variability, reduced kinematic redundancy, and capacity for motor equivalence. And perhaps there's a restricted number of movement patterns available. People get locked into certain patterns and they can't adapt those patterns. They can't form effective functional synergies. And there's also the appearance of abnormal synergies. This may be related to the observation of compensations and the ability of the nervous system to find a solution based on a limited set of synergies. So shout out to the rehab people that we shouldn't keep looking at doing more movement as trying to improve outcome, but we should look at trying to find ways of increasing TSRT regulation in order to increase adaptability, the ability of a patient to adapt to their environments rapidly and effectively. I thank all the students and teams involved in the research over the years, as well as my funding from Canadian and other sources. Okay, thank you very much.
Mindy, thank you very much. I think you better look into the chat, because at first I tried to respond to some of the questions, then I realized that many of the questions are quite specific for clinical issues, and so I think you should take a look and try to answer those that I kept open.
What do I know? Did you delete? How do I know which are kept open?
Well, you can see my responses. So some of them I did not respond to because I didn't know what to say, or I thought that that's something for general discussion. Okay, let's put the following. So, for example, there is very little difference between compensatory movement and normal movement in hand. I'm not sure what are the critical parameters that separate those from normal and compensatory. I'm not sure what is meant there, but
I think something something that's called compensatory has a negative connotation, and we consider it. So, I mean, in the rehab sense or in the disordered movement sense, we consider compensation as being something not undesirable. But compensation is another way of saying adaptation in the non-clinical environment, non-clinical literature. So compensation is not necessarily a bad thing. Okay, I mean, certainly we adapt, we compensate, we compensate, that's fine. And it shows it's just another way of enjoying the variability of the system and the adaptability and the abundance of the system. So it's a really good thing. But it's only a problem if it's the only way you can move. So we should maybe change the word and call it something maladaptive compensation, maybe. Sometimes that term is used. So we're only talking about compensation when it's maladaptive. When the compensation occurs that doesn't help you recover movement patterns that are potentially recoverable because it's taking over for them. So this is a big debate in the rehab community. So if you have a patient who is in the hospital for only a very short period of time, it's easier to let them find compensations and become more functional faster and send them home than to work on trying to recover movements that were lost. For example, if somebody's only using their non-affected limb and not using their affected limb at all, should you teach them how to do everything with their non-affected limb, open cans, eat, whatever, cook, okay, and so they could go home and feed themselves, or should you keep them longer in the hospital, work harder with them, force them to use their affected limb to recover some movement in their affected limb? This is a rehab question. It's a health services question. It's really, if we had the time, we would do it. Because we know from especially Teresa Jones's work, that if you allow somebody to stay all the time, they have learned, and it's called learned non-use. This was actually described by Howard in the 50s, 60s. Okay? So there's not just learned non-use, but there's also learned bad use. So you can learn how to do it. You can have a reorganization of the cortex that reinforces the patterns of abnormally bad movement. And when you do that, it's very difficult. And Bernstein said this, I have a quote from Bernstein, saying that when somebody learns how to compensate or do something in a certain way, it's harder to get them to unlearn that and relearn the new pattern than to relearn the new pattern from the beginning. And it was a very nice observation by Bernstein.
That was not only about patients by Bernstein, who in general had a statement that breaking a bad habit is extremely hard, much harder than learning a good one from scratch. Yeah. But that's, Okay, Mindy, for the patient with spasticity, if we neglect the spasticity and continue to give them normal task movements, will it affect the overall recovery of the patient? Or should we solve the spasticity problem simultaneously with task movement training?
Yeah, I agree with the second statement. We should try. But right now we're not, okay? So there was a study done where the task was to reach a target, the training was to reach a target quickly and precisely. And the person did not take into account the spasticity zone, okay? So in order to reach the target more quickly and more precisely, they learned how to use their trunk more. So in the training, they just learned how to compensate better. And they learned how to compensate very well, and they actually did much better at the task than they did before the training. But that's at what cost? So that's the same question as we just asked before. So okay. I think we have to find a compromise. We have to find a way. And I think we have now early evidence from the study by Turpin and also the study by Daniele Vigitelli that there is capacity to change the TSRT. It's very encouraging, and we want to continue looking into those mechanisms.
Okay. Question, how is TSRT measured? And then is a follow-up, although by a different person, is there a difference between the dominant and non-dominant arms in stroke patients?
Is there a difference in the TSRT? Is there a difference in what?
TSRT. Is there a difference in TSRT between the dominant and non-dominant arms Well, of course, if you take into account the stroke side.
Yeah. Okay. So the question is there a difference in the TSRT in a spastic muscle on the dominant versus the non-dominant side? Yeah.
And how do you measure it? That was the first question.
Well, okay. So the second question we don't know. So that's a good experimental question that can be addressed. The other question, how do you measure the TSRT, is you need to simply do what we did was by stretching. The person is at rest. You have EMG electrodes on the agonist and on the antagonist, an electrogoniometer or a way of measuring the joint angle, and then you stretch at different speeds. And we actually have a procedure for doing that. We have an algorithm on a computer and a system that we set up so we can measure this not necessarily in the lab, but in the clinic. So in the lab, you can use a torque motor, very nice. But in the clinic, we have the TSRT device or the algorithm for the computer, and the therapist is the motor. The therapist stretches at different speeds, different stretches, and then the regression algorithm ensures that there's certain criteria met before the stretch. Number one, that the EMG is quiet before the stretch. The person's really at rest. And you have the EMG electrodes, you can monitor that. And the second is that the initial position is the same. So we pick the initial position and repeat for the stretch from there. The skill in do bell stretches and not, of course, the response, the stretch response in the muscle is affected by acceleration. So if you stretch quickly and then slow down or little jerky things at the response, and the therapist has to learn how to stretch at different speeds, which is not so simple to teach somebody that they should stretch slow, medium, and fast. Most of the time when people start out there, there's a central tendency. They all stretch at the same speed over and over again, and then you'll just get a ball of data points in the middle, and you won't be able to get a regression line. So you have to record something in order. You can't measure the TSRT. Alternatively, you can approximate the TSRT by a single, very, very slow stretch. And you can do that but you still need EMG electrodes, and you still need to measure the angle in a precise way, the joint angle. Because this is the critical. You need to know at what joint angle does the EMG start to contract.
Okay, there is a question about the RNC commands, because you talk about TSRT, which is measured in a muscle group, I assume.
Yeah.
So the effects are what happens in the abnormal motor control in terms of RNC commands, and is there a function of the C command in abnormal control?
That's a good question, and we have done a couple of studies on C commands in stroke patients. I refer you to a study by Levin and Dimov, or Dimov and Levin, I don't remember the order, 1997, okay, where we did a classic unloading task, all right? And in a classic unloading task, when you unload the limb to different levels, the limb stays where it's unloaded to. So you start with a certain load, you partially unload the limb a certain amount, and the arm goes to a new position, and then you start again, you partially unload again, you go to another new position. We looked at the unloading, partial unloading to full unloading, and we looked at the EMG activity in both agonist and antagonist, flexors and extensors, the elbow. And essentially, in a healthy subject, when you partially unload, you stick the final position by coactivating. Okay, so you have a certain coactivation there. And when you get to the end, when you completely unload, you're no longer coactivating. You're basically you come to rest. So, but there's a zone in this unloading space the single joint, where you can see the muscle coactivating. And you need that coactivation in order to stabilize the final position. In the patients we studied, we found a whole bunch of different behaviors. First of all, we unloaded from 2 different positions, and we also found that some patients had no coactivation. So when they would get to the end, after the partial, and their arm would just oscillate around the position because of lack of coactivation. So the problem, and I think the other study we showed that there was a problem in the specification of coactivation, that it was specified abnormally when the arm was being stretched, while the flexors were being stretched, where it shouldn't have been specified at all. So we think that the patients, that stroke affects the ability of the system not only to regulate the arc command, but also the C command.
Okay. All right, Mindy. So I think maybe I missed something. If I did, if there are still questions from the chat that I somehow missed, please ask them. Well, unmute yourself and ask them. Or you can just unmute yourself and ask Mindy anything you wish.
Maybe.
Yes, Mindy, is Jose. I would like to ask one question regarding the experiment.
Sure.
Yes, the distance between the patient and the object that is supposed to catch, is it standard, or the limb mass could influence the motor behavior?
Which experiment are you referring to?
When there were 3 patients, depending on severity, they had different behavior when they were picking up the object from the table.
Okay, you're talking about the one where the person leaned forward to touch the target?
Yes,
So
correct.
the target was always at the same distance with respect to the individual. It was a percentage of their arm's length. Is that your question?
Yeah,
So that the now this is really important when you're doing any kind of reaching experiments and comparing between people, because people have different arm lengths, and when they're reaching, when you're doing a reaching experiment, you have to take that into account. So the target always should be, if you want to do any across group comparisons, you have to normalize the target distance to the individual.
Okay, thank you.
Mindy, I have, it's a theory, a relatively minor question, but still it is directly related to the equilibrium point theory and threshold control. You mentioned at the patients have, but on the other hand, we know that motor neurons innervating slow and fast fibers have quite different thresholds. So could it be that part of your results can be just explained by muscle fibers?
That's an interesting question. You're right. I think to some extent it can be, you should be able or should take into account muscle fiber the influence of muscle fiber composition when you're dealing with very chronic patients. So there's a classic study by Volker Dietz where he looked at gait, and he was trying to measure spasticity in the muscles of the ankle. And he observed that there was no spasticity in these patients because they all had basically changes in muscle fibers, and that all of the resistance to the ankle dorsiflexion was due to this change in muscle fibers and actually what we call contracture in the muscle, but there was no abnormal EMG. When there's an abnormal EMG, though, analyze the EMG signal to see if we can identify different muscle fiber types. It's something to take into consideration, I think, especially for more chronic patients.
Mindy, sorry, this is Raoul here. May I ask a question? Sorry.
Sure.
Thank you for the talk first. I really liked it. So I was thinking about relating the uncontrolled manifold to this. And I was wondering, in particular, when you told about this trunk blocking experiment, you show that the endpoint trajectory is the same, but the joint angles are different.
Yeah.
And basically what you do then in the experiment, you shift the person on the uncontrolled manifold, because you just keep performing the task, but you shift them to a different region of the uncontrolled manifold. Now, when you did the same first part of the trajectory with the endpoint, and then they sort of fell off. And perhaps this is an open door, but struggling with it when you were talking. Manifold is shaped different. I mean, it has to some extent. But that determines the shape of this uncontrolled manifold, which is determined by the part their physiological characteristics, right? And that might be that some places the uncontrolled manifold is narrower, so to say, and that makes that you fall off the uncontrolled manifold, which makes that you cannot perform this task anymore.
Yeah, I think there's been a few studies on uncontrolled manifold in literature, starting with Darcy Reisman.
Yes.
And John Schultz. They showed, I think there were some changes, but not that. Actually, we did Yusuke Tomita, who did this pointing experiment. Used a UCM analysis on the on his reaching task, but I'm trying to remember what our final conclusions were. Daniele, do you remember? Maybe he was co-authors. Maybe he'll remember more.
We studied the two salient variables. So that was the endpoint and the center of mass. And the center of mass, I think, was more preserved than the endpoint trajectory.
UCM.
Yeah.
Because we had the initial, the same configuration at the initial position, and we had of course, the final. But we didn't look at it in terms of the shape of the UCM, I guess. It's something we could consider.
Well, the thing is, because your advice to the Rehab is to increase this TSRT range. But you can only increase the TSRT range within the UCM, otherwise you cannot perform the task.
Yes.
So there's a constraint. The UCM gives you the constraint on how you can apply the experimental settings to increase these TSRT range. That is sort of the step to the clinical application for that. So if you combine those measurements of the TSRT and the uncontrolled manifold, that would give you some constraint as to open up the system, so to say, and where there is not. That is the background of the comment.
No, that's a very good suggestion. I think that's actually something that Daniele wants to do. You were going to do it for a reaching task in sitting, but then the pandemic happened. Things got messed up. Hopefully, we'll still do it.
Yeah, one of the experiment was to first detect the TSRT in flexors and in extensors, and then doing a reaching task and measuring the uncontrolled manifold in the reaching task, and then compare the TSRT with the UCM data, with the VORT and the UCM data. Yeah.
Well, that's kind of like what you're saying, Raoul, but I think Raoul actually made another suggestion, is to see what is the degree to which what are the constraints? What are the UCM constraints within which the TSRT can be regulated, and to what extent can we, Although I think the problem with patients is that their limitations are much greater than the potential UCM space. So I think there's a lot of room there.
Yeah, that this might be one. Yeah, I have to think about the and look at the movements. But you could. What we do currently is we do not compute the variance of the uncontrolled manifold, but project the actual joint angles on the uncontrolled manifold, and then you can get a kind of a you're not tied to the variances, but you see directly what people are doing in the joint space. At least you get a measure of that, so to say. Yeah. And you can look at the contributions of the individual joints in that. This might be a suggestion to try to combine this.
Oh, thank you. Yeah, let's do it.
This is why we need lambda meters.
Yeah.
Because we cannot study UCM effects in that space because we cannot measure these variables well.
During movements,
yeah, during movements, of course. Okay, any other comments for Mindy or questions? Then, well, let's thank Mindy one more time. Very nice, thank you. And a reminder to everybody, we meet again on Wednesday. And we will try, well, I'll try to distribute your questions to the speakers and we'll try to get ready. So if you still have questions that you haven't sent me, please do so quickly because otherwise they may not get into the mix. So thank you all very much. Mindy, you all in a couple of days.
Okay.
Bye-bye.
Thank you, everybody.
Bye-bye.
Okay.
Thank you, Mindy.
Okay, thank you, Danielle. And waiting to hear the good news.
Yeah, let's wait.
Okay. Okay. All right, I'm gonna hang out. I'm starving. I'm gonna eat. All right, bye.
Bye, Anatol.
Bye, Daniele.
Yeah,
Nice to
see you in person tomorrow.
Tomorrow or Wednesday.